Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning and Obesity Canada. My name is Denise Campbell-Scher. I am the Associate Dean for the Office of Lifelong Learning and the Physician Learning Program, as well as a family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines for adult obesity. The new 2020 Clinical Practice Guidelines are expansive. 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over a few items. We acknowledge that we're on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Please contribute your experience with obesity management to our advocacy and programming. So if you're waiting or after the event, please take 5 minutes to contribute your perspective by scanning this QR code. So it's my very great pleasure to introduce Dr. Yoni Freedhoff to present our webinar on commercial products and programs. Dr. Freedhoff is an Associate Professor of Family Medicine and Medical Director of both the Bariatric Medical Institute and Constant Health. Yoni is an outspoken public health advocate, and his book, The Diet Fix, was a #1 national bestseller. His blog, Weighty Matters, has enjoyed over 24 million visits. He also suffers from some unnamed pathology that has him spending far too much time on Twitter. So it's my very great pleasure to introduce my Twitter friend, Yoni Freedhoff. And Yoni, with that, I'm going to turn it over to you.
Hi there, I'm Dr. Yoni Freedhoff, and I'm an Associate Professor of Family Medicine at the University of Ottawa. Thanks to Obesity Canada for inviting me to give this talk today, as well as to including me in the creation of the guidelines. And my job today is going to be to discuss commercial products and programs in obesity management as a general overview. And so before we start with the actual talk itself, let's go to some disclosures. So I think for sure the most pertinent disclosure for me to make is that I'm the co-owner and medical director of a community-based interprofessional behavioral weight management office, Bariatric Medical Institute here in Ottawa, and it receives funding from the Ministry of Health. I'm also the co-owner of a web-based dietitian-delivered virtual care program called Constant Health, which in turn received an unrestricted grant from Novo Nordisk to fund 700 Canadians' Constant Health programs. I'm the author of a blog. It's non-monetized. It's called Weighty Matters. It does have me publicly sharing my opinion on matters related to weight loss, the weight loss industry, and more, as do many of the columns, articles, and interviews for other publications and outlets that I've given. I actually think that the public expression of opinion is a very pertinent conflict of interest for speakers to declare, because it is a human trait to find it difficult to go back on things that we have already claimed to believe in or think are true. And finally, I should point out that I wrote a book called The Diet Fix, Why Diet Fails and How to Make Yours Work. It was published by Random House in 2013, and I do occasionally receive royalties from it. And so to kick things off, I actually have a quote from a book from a collection that I've been amassing for many years. I collect antique weight loss memorabilia, advertising, gizmos, books, etc. And you actually, if you wanted to, could see some of these on display at Toronto's Ontario Science Centre. And this book, Your Weight and How to Control It, was written nearly 100 years ago now, in 1929. And it included 15 leading medical authorities, scientists, and associated experts to bring up-to-date and reliable medical information on all aspects of weight control, the factors affecting overweight and underweight, and their relationship to your total health and your appearance. It includes practical diets and scientific methods of weight reduction. It's actually a terrific little book, and some of the concepts in it are very valid today. Among them, their thoughts around fad diets, which amazingly existed back then as well. And not only fad diets, but the predation of the weight loss industry on individuals. And so there's a quote in this book by a physician named Arthur Kramp that I wanted to show to you and discuss with you. And here it is. So Arthur Kramp, 1929, an intensive study of medical frauds and fads made over a period of nearly 20 years has convinced me that in the whole realm of quackery, there is no field that is more easily worked, nor one that offers greater financial returns to the medical swindler than that devoted to the exploitation of cures for obesity. And of course, that continues today. We know that the sort of weight management industry globally is expected to generate nearly $300 billion of annual revenue in the next few years. And so this is a very large area of interest for swindlers, because there is a lot of money in this area to be had, because people are desperate and society has convinced them that this is a medical emergency. Now, when it comes to obesity in our clinical practice guidelines, we define it differently perhaps than much of the medical community, where rather than simply discuss how big a person is, which is what BMI measures, it is literally a measure of bigness, we talk about the definition of obesity being a complex chronic disease in which abnormal or excess body fat or adiposity impairs health, increases the risk of long-term medical complications, and reduces lifespan. And so when it comes to the treatment of a chronic condition, treatment matters when it's causing problems, and that's why this chapter is important. There are patients out there who are suffering with obesity, who have medical consequences of obesity, and they are seeking help. And not all practitioners are trained on their own to provide that help, and there are a lot of people and products out there that are calling to our patients regularly. So ensuring that physicians have an overview of what is going on in their communities is crucial. And so the key messages for healthcare providers to remember is that they need to familiarize themselves with the commercial obesity management offerings in their practice vicinities. Look through the yellow pages or the virtual yellow pages. Look online on Google and see who is offering what services to your patients. There have been criteria published to evaluate whether a commercial program is safe and potentially successful. Briefly, it might offer a combination of nutrition, physical activity, and behavior change support. It may suggest realistic weight loss goals of 0.5 to 1 kilogram a week. It might include a long-term weight maintenance approach, have a good safety profile, and have reasonable costs. There are also many products on the shelves of our pharmacies. Unfortunately, none of the weight loss products from the commercial industry that were studied in randomized controlled trials of more than 12-week duration were shown to produce clinically meaningful weight loss. And these products are being sold in pharmacies. This is actually a photograph that a friend of mine took in a local pharmacy in Manotick, Ontario, back in the day that raspberry ketones were the thing, as seen on Dr. Oz. But it really was shocking to my friend, and perhaps shocking to me, although I don't shock easily with these sorts of things. But this was a display that was directly in front of the pharmacy drug pickup counter, conferring a lot of authority and belief to the potential efficacy of these raspberry ketones, which we know from clinical trials have not been shown to be particularly exciting unless perhaps you're a mouse taking thousands of times as much raspberry ketones as people tend to be offered. And so I want to go through a few of the more commonly prescribed or commonly seen items. I shouldn't say prescribed because they are not prescribed, they're over-the-counter products, but for weight management. And they're in no particular order, and these are just some products that were covered in our chapter on clinical programs and products. And so one is PGX, so we can see clearly what the advertisement is referring to. And I should state for the remainder of this particular presentation, there may be some stigmatizing imagery from the advertisements from both the weight loss programs and from some of the products themselves, like this one. According to this advertisement, it's ridiculously simple. It promotes healthy weight loss, lowers cholesterol, and balances blood sugar. And there's a lot of asterisks there. If we look to PGX, PGX, or polyglycoplex, is a highly viscous fiber. It's purported to help decrease appetite, manage body weight, improve glucose, insulin, and cholesterol metabolism. A 2015 meta-analysis of double-blinded randomized controlled trials looking at PGX concluded that the available evidence does not indicate that PGX causes reduction in body weight, though it may cause reduction in both total and LDL cholesterol. 2017 meta-analysis of soluble fiber supplementation as a whole, this is a soluble fiber, on obesity management found that while supplementation did associate with weight loss of about 2.5 kilograms, they recommended caution in interpretation be exercised given what they called the considerable between study heterogeneity found. I've seen this being sold in all pharmacies and in large displays, certainly in Costco. Garcinia cambogia was promoted also by Dr. Oz, just like those raspberry ketones. According to this particular product's bottling, it supports weight loss, has non-GMO ingredients, and it has 5 times more per serving. Garcinia cambogia, it's a small fruit. It's popular in cooking in southern India. It's also purified and marketed to offer obesity management, appetite control support, and more. Its putative mechanism of action involves the inhibition of citric acid lyase by way of its hydroxycitric acid. A 2012 meta-analysis concluded that there's little evidence to support the use of Garcinia cambogia, and there's also some concern for liver toxicity consequent to the use of Garcinia cambogia and supplements containing Garcinia cambogia. A 2018 literature review reminded physicians to actively monitor patients taking these products for changes to their liver function. Here we have another common weight loss product. It's green tea extract. According to the advertising, healthy weight loss, natural energy, immune system support. The bioactive components of green tea are their polyphenols, whose proposed primary mechanism of action involves increasing energy expenditure and fat oxidation. Reviews of green tea in obesity management have not demonstrated clinical efficacy with either weight loss or weight loss maintenance. Next up is chromium picolinate. Chromium picolinate, according to this advertisement, is for fat loss, for muscle mass, for insulin control, for lower cholesterol, for hypoglycemia, and long life. And this was from Puritan's Pride, yeast-free chromium picolinate. The actual product, chromium picolinate, is said to stimulate neurotransmitters responsible in eating behaviors, improving glucose metabolism and insulin sensitivity. A 2013 Cochrane review concluded that there was no current reliable evidence to inform treatment decisions as to the use or the safety of chromium picolinate supplementation for the treatment of obesity. Here we've got Chitosan, although I note too that this particular version of it also has chromium. It's for, according to it, weight management. It is super fat absorbing. Now, Chitosan is a polysaccharide thought to reduce the absorption of dietary fats from the gastrointestinal tract. A 2008 Cochrane systematic review assessing 15 trials, including 1,219 participants, found that Chitosan supplementation led to a 1.7 kilogram greater weight loss, which it described as minimal and unlikely to be of clinical significance. And here we've got glucomannan for weight loss. Glucomannan is another soluble fiber. It's thought to delay gastric emptying and in turn increase satiety and reduce dietary intake. At least that's the putative mechanism of action. A recent systematic review of 6 short randomized controlled trials came to the conclusion that there was limited data to support that glucomannan supplementation may help to reduce body weight, but not body mass index, which means it must have been a very small amount of weight loss. Now we've got SlimFast, so it's not a supplement per se as a product, but rather a meal replacement, and it's certainly readily available. It's a self-directed program as well, based on low-calorie meal replacements with online nutrition support and coaching text messages. 4 randomized controlled trials compared SlimFast with control and just education, and 4 randomized controlled trials compared SlimFast to counseling. The results were mixed, with most only reporting on completers. One study did not show any difference regarding weight loss between SlimFast and education, but most of the studies showed a difference in weight loss between groups ranging from 5.2% to 8.7% and in durations of between 6 months and 51 months. Compared to purely behavioral intervention, SlimFast showed a modest weight loss difference, ranging from 0 to 3.4% more weight loss at 3 to 12 months. But as we get into discussing the programs per se for weight management, I do think it's important to discuss the privilege required to complete these programs, to be involved in these programs, and to sustain these programs. And so intentional behavior change in the name of health, whether it's for weight management or anything, requires a great deal. Financial stability, perhaps, mental health and physical health, not having tremendous caregiver responsibilities. And remember that we're talking about a chronic disease, and so that means that treatment must be lifelong. Chronic diseases require long-term treatments. There are no sort of antibiotics that make this issue change or go away over time. And so when we think about the average person in society today, especially today with COVID-19 and the added stresses there, life's challenging. And this idea that we simply should be able to will ourselves to intentionally change our behaviors around food and fitness in perpetuity in the name of weight management or health, I think it's really unfair for a huge percentage of the population. I would argue perhaps even the vast majority of the population. And so when we are talking about these programs and behavior change in general, I do want you to take some time and reflect on the realities that your patients face on a day-to-day basis and whether you think it would be fair to even consider the possibility that they could, if they wanted to, prioritize thinking and actions around weight management simply because their weight is higher than some table says it should be, or even if it was causing medical problems. 80-85% of all chronic non-communicable diseases have lifestyle levers that would either help to treat them or perhaps to prevent them. Yet there's generally only moralizing around obesity, and I do think that's an overarching thought to keep in mind as you consider weight management programs for your patients and as you reflect on what you'll be recommending to them in your offices. And something else to keep in mind when considering weight loss programs are that these are services. Services are provided by individuals who have different skill sets and different abilities to connect with patients and to inspire change. This is Dr. Nick Riviera. If I kill you, you don't pay, which sounds like, I suppose, a fair deal. But all this to say that these are services, and as a consequence, it's challenging to think that every single program of a particular brand of weight loss provider is going to provide the same benefits. You may have better and worse service providers within the same program. And that goes for physicians as well who are involved in weight management. I mean, we're all speaking the same language, giving people roughly similar advice, but the service provider matters a great deal. And I wonder, too, how much that impacts the various outcomes in the various studies of various programs. Because, again, it's going to be dependent on the skill of the service provider to a large degree. The other thing that I'd like you to keep in mind is that there are success stories with every program. This is a waterfall plot. This is not of any diet programs. This is of a diet study. This is the Diet Fit study, Chris Gardner's study. But I love the plot. Every single line in each of these waterfall plots is an individual, and it reflects how much weight they lost after a year being given some low-carb or low-fat advice and counseling. And I include this just to point out not that there's no real difference between the outcomes of low-fat and low-carb diets. That's a different debate for a different day, although that's certainly what the data would support in this case. But what I think is really important to point out is that there are success stories with virtually every program out there. I'm very agnostic when it comes to what programs people want to choose and explore. For me, what matters most is whether a person enjoys what they're doing in regard to their weight management efforts enough to keep doing it. Adherence is king when it comes to weight management. But when people ask me, for instance, in my office, can you comment on this program or that program or the other program, one thing I will always point out to them is that there is yet to be, we don't have a gold standard that suits everybody. There's a lot of different people out there with different reasons for liking different approaches. And so I think it's important to know about the different approaches, but it's difficult for anybody to suggest that there is one best approach that will work for everybody. And I think that you should be leery of anybody who suggests that there is. And so going through some of the programs, let's start with the biggest and perhaps the most established, which is Weight Watchers, and it's been rebranded as WW. It's important to note, if you think back to what we were talking about service provision, since 1997, WW has changed its program 8 times. And so it really is difficult when we discuss the outcomes of various studies of Weight Watchers to determine whether they're applicable to new iterations of the program. Generally, the program's a point-based food plan. It's individualized according to sex, age, and weight. It has online tools with tracking, support groups, goal setting, and communities. The support groups or workshops can be in person as well. There's now online version. And the program focuses on low-calorie diets composed of conventional foods, but certainly they sell their share of supplements in the supermarket as well. And they encourage increases in physical activity and behavior modification. In the 3 large studies with 1-year results, the difference between percent weight loss change of the Weight Watchers group versus the control group at 12 months was between 2.6% to 3.2%. A recent randomized control trial in the primary care context compared a brief intervention to 12 weeks or 52 weeks of Weight Watchers. At 12 months, the brief intervention had lost an average of 3.3 kilograms. The 12-week Weight Watchers group had lost 4.8 kilograms, and the participants in the 52-week Weight Watchers program lost 6.8 kilograms. At 12 months, this is impressive. 57% of the participants in the Weight Watchers 52-week programs had lost 5% or more of their initial weight, compared with 42% in the 12-week program and 25% in the brief intervention group. Although I have to point out, 25% losing 5% or more from a brief intervention, that sounds like a very good brief intervention. Moreover, when we talk about the 52-week program, 10% weight loss was achieved in 30% of participants in Weight Watchers versus 9% in the brief intervention group. The differences between these groups remain significant at 2 years follow-up. There's also been studies on Weight Watchers' impact on blood pressure. A systematic review of randomized controlled trials studying commercial programs found that there was no effect on systolic blood pressure. Half of the studies reported small effects on diastolic blood pressure, and they also happened to show small improvements in triglycerides, LDL, and HDL. These studies were reported, however, to have a high risk of bias due to attrition. When it comes to blood sugar, randomized controlled trial of 563 adults with type 2 diabetes in Weight Watchers, combined with telephone and email consultations with a certified diabetes educator, was compared with standard diabetes nutrition counseling, and the Weight Watchers group showed greater weight loss, 4% versus 1.9%, and improvements in A1C, a drop of 0.32 versus 0.16. And were able to reduce their diabetes medication 26% of the time versus 12% in the standard care group. These patients also had significantly greater improvements in weight-related quality of life and a decrease in diabetes distress score. So by far, Weight Watchers is the most studied of the various weight loss programs out there. We've got Ideal Protein, which certainly many of us in Canada will see at various pharmacies. It is offered at least through the PharmaSave brand of pharmacies. It's a ketogenic meal replacement program. Its main approach is based on consuming ideal protein foods with a progressive transition to regular food. The program offers one-on-one coaching with healthcare practitioners or coaches and online coaching support. Again, it's sold by drugstores or Ideal Protein clinics. However, there is no data in the literature regarding the efficacy, safety, or the improvement of cardiometabolic risk factors associated with this program. We've got Jenny Craig. So Jenny Craig's been around for quite a long time as well. Jenny Craig offers weekly individual sessions via telephone or face-to-face with behavioral counselors, a low-calorie or low-carb diet with prepackaged meals, and an online tracking method for food journaling. One randomized controlled trial compared Jenny Craig with control and 2 randomized controlled trials compared Jenny Craig with behavioral counseling, and Jenny Craig resulted in a 4.9% greater weight loss than control or behavioral counseling at 12 months, regardless of whether the Jenny Craig program delivery was in person or by telephone. Attrition was less than 20% in these studies, although unlike in real life where you have to pay for the Jenny Craig foods, in these studies they were provided to participants. Adherence was not reported, and 3% of participants, although that was only one individual, required a cholecystectomy. We do know that rapid weight loss or weight loss in general increases the risk of gallstone formation, so perhaps that's not surprising or unique. NutriSystem's been around for a while as well. It's a commercial-based program based on individual counseling, exercise plans, and online tracking for food journaling, and a low-calorie diet with meal replacements that you buy from NutriSystem. 1 randomized controlled trial compared NutriSystem with education, and 2 compared NutriSystem with behavioral counseling. NutriSystem resulted in 3.8% greater weight loss than control or education at 3 months. However, there were no studies continued out to 12 months. Optifast programs, they are based primarily in Canada. They're medically supervised, and they include high-intensity behavioral intervention combined with a low-calorie meal replacement diet of 900 calories per day. Among program completers, weight loss was between 15 to 25% of initial body weight during the 3 to 6 months of treatment. Weight loss maintenance was about 9% after 1 year and 4.7% of their initial body weight after 4 years. But that data only reflects the 50% of the initial cohort that participated in the long-term follow-up data. Attrition was high at between 45 to 56% after 26 weeks of treatment. However, it may reduce A1C by 0.3% more than conventional counseling after 6 months, but long-term data about A1C control have not yet been collected. Reported side effects of Optifast are constipation, fatigue, headache, hair loss, and biliary colic. There was a reported cholecystectomy rate of 0.2% after 6 months. Optifast is also being used for pre-surgical weight loss, both in the context of shrinking a person's liver prior to laparoscopic surgery, often laparoscopic bariatric surgery, and also at times it's used in patients with much higher BMIs to influence which surgery they're offered. Overeaters Anonymous is a non-profit self-help program led by peers. The program is free, and their philosophy and 12-step approach are similar to that of Alcoholics Anonymous. There's no published study of the efficacy of Overeaters Anonymous for weight loss, and scientific evidence is minimal to recommend self-help programs like Overeaters Anonymous at this point for weight management. Finally, I've got TOPS, or Take Off Pounds Sensibly. It's a self-help non-profit weight loss program that recommends low-calorie diets, featuring a curriculum on diet, physical activity, and behavioral modification, with weekly group sessions led by peers. A retrospective cohort study of participants in the TOPS national database who renewed their annual membership, so not only completers, but people who want to continue staying there, showed a mean % weight loss in the first year of -6% for women and -6.3% for men. The 1-year retention was 36%, and the 7-year retention was approximately 6%. There have been no randomized controlled trials on TOPS and no data about metabolic outcomes. And so the key message is that there are a lot of programs out there and that they can be used to induce modest weight losses. Some of these programs have been shown to improve glycemic control in patients with obesity and diabetes, but there haven't been any that have been really demonstrable in having an impact on lipids or blood pressure at this point. As far as this chapter's recommendations go, we recommended that for adults living with overweight or obesity, the following commercial programs should achieve mild to moderate weight loss over the short or medium term compared to usual care education. That'd be Weight Watchers with level 1A grade A evidence, Optifast level 1B grade B, Jenny Craig level 1B grade B, NutriSystem level 1B grade B. Also, that Optifast, Jenny Craig, Weight Watchers, and NutriSystem should achieve mild reduction of glycated hemoglobin values over a short-term period compared to usual counseling in adults with overweight and type 2 diabetes, level 1B, grade B. We do not recommend the use of over-the-counter commercial weight loss products for obesity management owing to lack of evidence, and we do not suggest that commercial weight loss programs be used for improvement in blood pressure and lipid control in adults living with obesity. When it comes to the messaging for people, or the key messages for people who themselves are living with obesity, I think the most important one to keep in mind is that the weight loss industry is a big one and that not all of the players are good guys. It's characterized by unrealistic advertising and by promises that are perhaps not grounded in evidence. So before adhering to a commercial weight loss program or using a commercial weight loss product, people with obesity should try to ensure that the approach is safe and potentially effective. In considering obesity management products, the American National Institutes of Health, the NIH, published a short guideline for patients and practitioners detailing what to look for in a safe and successful obesity management program, and they included programs that involve behavioral counseling, including the use of food and activity records, discussion around social determinants of health and their impact on weight, discussion around the risks and benefits of medications for obesity management. They provide ongoing feedback, monitoring, and support within the program. They recommend weight loss goals of 0.5 to 1 kilogram weekly. They have a component specifically designed to address maintaining lost weight, and that they have long program duration. The NIH says people should be leery of weight loss programs that promise weight loss without diet or exercise, promise weight loss while eating as much food as you want, promise spot reduction of weight from particular locations, promise overly rapid weight loss, and include before and after photos and personal endorsements that seem too good to be true. Other things for people with obesity to consider when they're walking down those supermarket aisles or pharmacy aisles that have many weight loss products on display. Although they are available without a prescription, none of them have been proven to provide clinically meaningful weight loss in high-quality scientific studies. And also, when it comes to the programs, there are programs that have been shown to be effective to produce modest weight loss, including Weight Watchers, Optifast, Jenny Craig, and NutriSystem. They're definitely not successful for all people. They are generally considered safe, and as I was mentioning before, there are success stories with every program out there. If you want to read the full chapters of, or this full chapter, as well as the other chapters in the Adult Obesity Clinical Practice Guidelines, you can do so at obesitycanada.ca/guidelines. Thank you so much for paying attention, and now I'll be happy to take your questions.
Thank you so much, Yoni. So I'm just going to remind the audience, if you can pop your questions in the Q&A box, and I'll just introduce also joining Yoni on the panel today is Dr. Sean Wharton, who was co-chair of the guidelines. Dr. Wharton has his doctorate in pharmacy and medicine, and he's the medical director of the Wharton Medical Clinic, a community-based internal medicine, weight management, and diabetes clinic. He's an adjunct professor at McMaster University in Hamilton and York University in Toronto, and he works as an internist at Women's College Hospital in the Hamilton Health Sciences. Dr. Wharton is a researcher and is qualified as a diplomate of the American Board of Obesity Medicine. So welcome as well, Sean. So thanks so much for the presentation. And I'm just looking here. I think in the Q&A, we don't have any questions yet. So
it's a pretty straightforward topic, I think, Denise. It's,
yeah,
I remember I was talking to Don before this saying that I'm not sure there'll be many questions because the messages are fairly straightforward. And I think they can be summarized simply as being that it's a really good idea for clinicians to make themselves aware of what's in their neighborhoods as far as weight management offerings go, because not all clinicians are providing weight management or obesity medicine services in their offices. And so knowing what's around them is a good idea. I think it's important for people who are seeking help to know that there actually are success stories with many different programs. And so doing your homework and exploring what options speak to you is not a bad thing to consider. But there is no data to suggest that there's this one superior program or approach for everybody. And then finally, that the pills that should not be sold by pharmacists, or really should not be legal for sale because they don't have any demonstrated benefits, and we don't have necessarily studies enough to know about safety profiles, and they're often adulterated with prescription drugs. None of them work. And those are very easy messages, I think, to remember for people.
Absolutely, Yoni. Those are very straightforward. Sean, I know, actually we do have, Lara has a question, sort of a follow-on for that, which is, if you have patients who are very convinced to try some of these non-evidence-based supplements, or perhaps worrisome approaches, where you're concerned about that, how would you approach a conversation with your patient?
So I think a clinician's job is to provide information free from judgment. And so when it comes to somebody who was asking about a particular product, I think my job would be to tell them that there might not be strong evidence to support its use. I think it would be important to tell people as well that there have been many recalls from Health Canada for drugs that have been, or for natural health products that were adulterated with actual prescription weight loss drugs in them. It's a very common area for recalls from Health Canada, or warnings from Health Canada. It's weight loss drugs and sexual enhancement products that tend to get those warnings the most frequently. I would tell them too that I would support them, and that, you know, they're welcome to try, but that certainly there's no data that would suggest it's a great way to spend their money. And that, again, my job is to give them advice and not to judge them on the advice that they choose. And then, of course, I'd want to explore what they feel that the medication or the supplement will be doing for them, in case there were ways to try to get the same benefit they're looking for, either through lifestyle change or through pharmacotherapy. When it comes to other programs and whether people should try other programs, it's certainly a constant question in my office about, you know, should I go do this program or should I go do that program? And again, I point out to them that there really aren't any proven superior programs out there, and that they should simply be cautious. And we go through that list of things that you might look for in a weight loss program. But I think it's important to encourage people to explore their options, because I think doing so is, first of all, ethical. I think we need people, we can't just tell people and expect people to do what we think is necessarily the right thing for them, nor is it reasonable to expect that we know what the right thing for them to do is. And then, of course, it's exploring that individual social determinants of health, perhaps even before the discussion, just to find out if the timing is right and whether there are other things going on. I see there's another question as well about ideal protein and suggestions to approach pharmacy about not working with ideal protein. I don't know that so I'm not sure that there's a case to be made, aside from the fact that we know that there is not strong data out there. I'm not a fan of some of the programs that are around, and they're probably not a fan of me at times too. So I'm not sure. And the other thing about the pharmacies that people need to remember is that it's not always the decision of the pharmacist in terms of what programs do and don't get offered.
Mm-hmm. Sean, did you want to weigh in on either of those first two questions? And then I think we're getting some more as well.
Yeah, so I am a pharmacist as well, before going to medicine. So I think the idea of, right, so I don't think it's going to be possible to stop that ideal protein program that the pharmacist is offering. So the reason why I'm saying that is because I think we can go back to why a lot of this is happening in the first place. And I believe that it's a lot of bias. And Yoni started off with this, the fact that the weight loss industry is one of the few areas that continue to have these bad players and this allowance of these type of products to come into the market or programs. And the bias is really, so bias is my opinion of this is such and such. I'm going to ignore the evidence. I'm going to ignore the biology and the pathophysiology and use my opinion instead of using actual evidence. And my opinion is that obesity is relatively simple, and you should stop eating so much and you should move more. And that's my opinion. And as a result, ideal protein is the right way to go. Having a low keto diet, just having dieting is the right way to go. Not thinking about the genetic biological components that are connected to the brain, and that cognitive behavioral therapy to strengthen the executive lobe would be beneficial, or pharmacological components. And why is there so much bias in weight management versus breast cancer? When breast cancer, we understand that there's a biological process, and that biology, that oncologic process requires us to use medications and to use surgery. And so we will not be able to sell a strange mustard paste to rub on the breast, or to be able to get rid of breast cancer in the local pharmacy. So the only reason ideal protein is there, and keto, and raspberry ketones, etc., is because of the intense amount of biases towards weight management, and people with elevated weight in our world and in this world. So I think that eventually the only way we'll get rid of ideal protein is as we get rid of our biases, and that requires education about the biological processes.
Yeah, and probably a follow-on I would add into that is just more research. And so one of the things I want to sort of make sure that people are aware of is that these are intended to be living guidelines. And so as new research becomes available, it will be incorporated on an active basis in the recommendations. And so hopefully we'll start to see a lot more trials and perhaps have more robust information. And I think that might, Yoni, lead into Melissa's next question, which is around something called NUM. And I'm assuming, I don't believe we found any information, correct? When you guys were searching for information, there was no research.
Yeah, there just isn't really any real information from NUM. So NUM is an online, very prominent sort of social media pushed program right now. It involves, at least at the beginning, and here, some of this is going to be hearsay for sure, so I should say that right out of hand, but my understanding is at the beginning there is interactions with an actual human being. I'm not sure what their qualifications are as far as training goes, but that over time, the human interaction decreases and sort of the artificial intelligence increases, and it's there to provide motivational support, keep food diaries, give you ideas of things to do, and some counseling. But as far as data goes, I'm not sure there's much. I do know that just the other day, actually, via Twitter, somebody shared with me something that NUM had shared to their clients, and it was very non-evidence-based, hocus pocus woo, at least that particular statement. But as far as the program's outcomes go, because you might make woo-woo statements and still get good outcomes, we just don't have any evidence or any information at this point.
So call for systematic study. And Bruce is just wondering, I guess, probably alluding to the fact that there might be just different populations in the study. So in the placebo group, it might represent different groups of people. And so just wondering if there was a lot of variability in the placebos. I'm not sure if you can comment on Bruce's question.
Some of the studies will compare to usual care, which is probably nothing. Some of the studies will compare to some in-office counseling or pamphlets, but absolutely there's huge variabilities in what constituted a placebo or what constituted the control group in these studies. And again, I mentioned it in the talk as well. Even if the studies are well designed, the notion that the results from one service provider will be the same as from another service provider is, I don't think, necessarily clear. I think the other challenge we see with weight loss studies per se, and this is me actually being more kind to some of these studies and programs, is we don't necessarily see an intention to treat analysis sometimes where it'll tell us, what percentage the average person lost in a particular program. But what we really would like to see are the responder rates. And, if there's a program that leads 10% of people to lose a substantial amount of weight, does that make it a good or a bad program? And do we evaluate outcomes? And Sean may be able to speak to this better than I can, because he's certainly more involved in research. But do we evaluate the outcomes of weight loss programs or obesity medicine programs in the same way we do medications? Or do we have a higher bar to clear when we speak of these outcomes compared to the bars that we would see with medications?
Mm-hmm.
Yeah.
So, sorry.
Definitely. Yeah, but definitely add that the doing stats in obesity research is very, very challenging. And so, and to the point that we have come up with things called estimans, and I won't go into that because we can't use intention to treat analysis anymore because it's not the same as a hypertension or a cardiovascular study. So obesity management studies and nutrition studies, as Yoni has pointed out, there's almost been no nutrition study on the planet that has ever been accurate because we can't do them. In 2020, we've not learned as yet, and maybe after we've died or in 20 years or something like that, there will be a way to do a nutrition study, i.e. comparing low fat to low carb or whatever you want to talk about. We just don't know how to do them yet. And people will talk about them and they'll have lots of people in the studies and then they'll say that such and such happened. And that's not true. We don't know. Nothing happened because it's not a real study. And so majority of the times we've had difficulty even with really good expensive studies saying that the data is actually valid. So that's our continual struggle. But I do want to answer this question about the struggle with the long-term follow-up with patients who've been on commercial programs and how do you engage them? How do you continue to engage them? There's a challenge with the long-term follow-up in any program. As Yoni pointed out, this is a chronic disease that lives forever. So you need to have a clinic that is around forever. You need to have a responsible family doctor, somebody who's interested, somebody who cares about the patient. The patient changes and they need different things at different times. So I do think that that's what you need. There's no way to get the patient back to that previous program or can sustain that weight loss that they had longer term, because that was 3 years ago, 2 years ago, 6 months ago. They're a different person. They may need different things. They may need to enhance and go towards cognitive behavioral therapy with a therapist or medications or different options. So that's the challenge. I have my baby in the background that's making noise.
Hello, James. We'll say hi to James in the background. Yoni, did you want to chime in on Ryan's?
Sorry?
Do you want to chime in on Ryan's question?
Just in terms of, I mean, it is difficult. So in terms of people who aren't engaged with the program, I think the most important thing to find out is why aren't they engaged with the program anymore, and explore what it was either about the program or their lives that they found either not helpful or challenging. You can certainly try to troubleshoot if there are things that are challenging and getting in their way that you might have the ability to help with. And the other, of course, thing to note is that you can redo programs and some people will have success. So it really is about exploring. What I tell people, regardless of what program they do, is the most important question is, did you actually enjoy what you were eating in your life while you were doing it? And if the answer is no, I will absolutely suggest that, well, maybe that's not the right program for you, because if you don't enjoy it, you're not likely to sustain it. But if somebody told me, listen, I was doing such and such a diet or such and such a commercial program and I really loved it, but then I got divorced and my life got discombobulated and I stopped, I would encourage them to consider going back. Why not? So it's always important to explore what made them stop, and also to have them reflect on whether or not it was useful. Without mentioning program names, there's no need to do that. I've certainly had people who tell me, oh, I did such and such a program, and I did so great on it, and I lost a ton of weight, and it's all come back, and it was really a great program. And I then want to explore if that program helped to set them up in any way, shape, or form for maintaining their loss. And then maybe reframe success, not in the context of how much a person loses or how fast they lose, but whether or not they're enjoying their lives, seeing improvements to their quality of life and or the impact that their obesity is having on their medical conditions, and that perhaps it's wiser to lose less more slowly and not regain it than to go back to the program that you're describing as terrific, but which really only helped you crash your weight down and did not support you to keep it there, and then you regained it afterwards.
One of the things too, I just want to chime in on this point for Ryan is, as a family doctor, when you're talking about taking care of people over a long time, 20 years, whatever, there's lots of other medical things that come up. So I think it's really worthwhile to look at the whole guidelines, thinking about other medical conditions that might have arisen that might be now upsetting the apple cart. perhaps obesogenic medications that someone might be on for another medication for another reason, or as you said, Yoni, like discombobulation and, you know, the personal circumstances, you know, a death in the family, you know, global pandemic, who knows? So there's many things that can upset sort of the apple cart when we look over a chronic disease frame forever. And so I think that there's other chapters that sort of go into some of that a little bit. Okay, so Fiona has a question about children. And so just a plug there, Fiona, there's going to be a new set of guidelines coming down the pipe for children that have just started. So these guidelines were about adults, but just Sean, Yoni, for kiddies, just some general advice that you might think about in terms of assessment for Fiona?
So I should say that my office does provide a Ministry of Health funded program for parents of children with obesity. So we, in my office, made a conscious decision to not include kids directly in counseling or care, but our catchment are kids between the ages of 5 and 12. The rationale there is still only theoretical in that, you know, there's been certainly studies that show, not surprisingly, I don't think, that working directly and only with the parents, the outcomes are comparable to programs that work with the children. I just worry about the potential inadvertent risks to children who are involved, especially at such a young age, in thinking about weight management and obesity, regardless of how gently and thoughtfully we might approach it. And I worry about potential risks to self-esteem and body image and relationship with food, and also the possible increase in things like eating disorders or lifetimes of yo-yo diets. But all that said, I don't believe that there's evidence to support my concerns either. And so there are, in many major urban centers, there are ministry-funded programs for children, some that involve the kids, some that don't involve the kids. And just like I was saying in respect to adults and adult programs, clinicians should make themselves familiar with what's available to them. If I was speaking to parents directly, I absolutely, and this is my bias speaking, but I would absolutely be encouraging them to approach it in a non-weight focused manner. And in fact, ideally, the best programs or the best approach would be the approach that the kid doesn't even realize is happening. Because again, I do worry about the potential impact on kids. And maybe it's just I'm not personally able to think of a way to counsel kids in a manner that feels safe, but there may well be people out there who do a tremendous job of it, but I would certainly be cautious, especially with the younger kids. But then, of course, as kids get older and they become more autonomous and they've got spending money and they're going out on their own when there's no pandemic, it becomes more complicated in terms of whether they should be involved or not. And I decided personally that we were not capable of dealing with teens, and so we don't. Good luck with teens, period. But all this to say, it's just be careful with the kids, because I've heard too many adults in my office talk about the well-intentioned doctor who first made them aware that there was, so to speak, a problem and led them on a lifetime of struggle and challenge.
Yeah, maybe I'll just chime in briefly, actually, because I have put a couple things in the chat box. So just to put a shout out to our colleagues, so Amy McPherson and her colleagues at Holland Bloorview in Toronto have done a lot of work on messaging for kids, as well as Stasia Hatnakis at CHIO in Ottawa has done a lot of work as well on tools and resources for kids. And both of them are engaged with these new pediatric guidelines, I believe. There's also the 5 A's for pediatrics on the Obesity Canada page, but specifically on that, how to have conversations with kids, both of these resources are really helpful. And so do attack some of those issues that you've been talking about, Yoni. Sorry, Sean, go ahead.
Oh, that was wonderful. That's great. So 2 great answers. So Arya Sharma taught me about 10 years ago or so. He said a prominent politician came up to him and said, my child is struggling with her weight. She's, you know, and we've been putting her on diets. We've been telling her to exercise. He said, whoa, stop right there. What you need to do is tell her that you love her. Tell her that you care about her and that you love her, and do exactly what Yoni said. An approach that does not talk about weight, does not talk about them decreasing calories and going on a diet. And they know their weight is a challenge. What they are looking for is the fact that they need to love from their parent in an appropriate way. Now, it's a simplistic way of talking about this, but it's important, and that's why we have to do interventions that are a little different than what we previously thought. And that's why we do not have any real interventions that have ever worked within the pediatric realm, because it's really, really hard. And I'm reviewing the pediatric guidelines now, so we're working on them. So yeah, it's been very interesting.
The last thing I would say in that topic too is that if you have a child under the age of 2 who's really experiencing rapid weight gain and concern, that is a child that should be referred, because if you're going to have a metabolic issue, it'll present in those little people. So just to keep that in the back of your minds too, if you're seeing something that seems just really out of kilter, those are kids to refer.
Sorry, Denise, I just want to jump in with something that you made me think of too, for the clinicians who are on this call, and also the parents or other people on the call. If there were a parent who asked for help, and then it turned out you had a discussion with them down the road and the child was losing weight, it would be really important to explore what's going on in that house, how much weight has been lost, just in terms of the context of safety and health. I think that seeing rapid losses on growth curves for children, for me, is certainly scarier than seeing gains.
Mm-hmm. Absolutely. So there's, Melissa has a question, and she says, we keep talking about weight loss as a goal, but is it possible that just won't happen? I've heard of a thrifty phenotype. How would it be possible and nutritionally adequate for these folks to maintain weight loss? So she's wondering about an explanation of this thrifty phenotype and how it affects obesity.
So I'm not sure in terms of the phenotype that's being referred to, but certainly there will be people whose best efforts don't see their weights change. And certainly you can improve health and quality of life without caring or focusing on weight as the outcome. And so one of the things I think is really crucial for people who are involved in working with patients is that we should be exploring the lifestyles of all of our patients, not simply only patients who struggle with obesity or only patients who ask for help. I think that the changes that we tend to recommend people make when it comes to nutrition, when it comes to exercise, when it comes to sleep and mood and self-care, they're broadly applicable, and they can have benefits regardless of a person's weight. And certainly in our office, we don't use weight as a goal whatsoever. But it's also important, I think, for clinicians to appreciate the fact that that is not an approach that will suit everybody, and that there are many people out there who get uncomfortable when you are not directly discussing and measuring and constantly talking about weight. And that involves then a lot of counseling by you to explain why perhaps that's not the marker and the be all and end all of trying to improve your health in the context of intentional behavior change.
Mm-hmm. Thanks. So I think the last question, just maybe it's just a point of clarification, Yoni. Cindy's just commenting on the recommendation that commercial programs should not be used for hypertension or lipid management.
So simply that there was no evidence to suggest that these programs provided benefits beyond sort of the control population's usual care. And I see the follow-up is, but they are leading to weight loss, and so shouldn't we expect to see change? And perhaps it's a function of the fact that the weight loss may not be sufficient in terms of amount to see those things change.
Right. Yeah. And again, these are living documents. So as evidence evolves and as we get more evidence, they may be updated. Well, I see we are at the hour. So I just really want to thank both of you, Yoni, for your talk, and Sean for joining and for the helpful answers. We did have a brisk and thorough set of questions. So clearly there were questions. And thanks both of you so very much, and also for all the work on the guidelines. And thanks also to all the attendees and to the colleagues at Obesity Canada and the Office of Lifelong Learning for all your efforts on putting on these webinars. And we'll carry on with them. And yeah, this is just super.